Good afternoon, everyone. Thank you for giving me this opportunity, and thank you for everyone being here to have this academic feast. So today's topic is my renal dysfunction in case of heart failure. We all know that heart failure patients are very frail patients, and they are at risk of developing renal dysfunction. And these patients, require utmost care. On top of that, there are a lot of kidney patients, renal patients who have who develop heart failure as their disease progresses. So I'll be shedding some light on that. So when we talk about both heart failure and kidney disease, if they both are there together in a patient, there is more risk of hospitalization. There are more rehospitalization in these cases. There is more need of intensive care. There is more need of kidney replacement therapy, and their death, that is the mortality rate, is also very high. So worsening heart failure has direct and independent consequences on heart failure symptoms and adverse clinical outcomes. Nearly half of all patients with heart failure experience CKD with higher prevalence. In acute heart failure, that is to the tune of 53% versus chronic heart failure, that is to the tune of 42%. In Swedish heart failure registry, we have a very high prevalence of nearly 57% who had heart failure with reduced ejection fraction and CKD at to the tune of 45%. And 21% had heart failure with mid-range ejection fraction and CKD. 22% had heart failure with preserved ejection fraction and CKD. So when it comes to both these diseases, they both are interrelated. When it comes to the kidney problems, there are three phenotypes that we have. First is there is some kind of intrinsic kidney disease that gets precipitated. Second is these patients are generally diabetic, and there is diabetic nephropathy, or they are hypertensive, leading to hypertensive retinopathy. So these are the three phenotypes that are generally there for kidney disease patients. At the same time, when you talk about heart failure, they are either heart failure with reduced ejection fraction, that is DCMP, or mid-range or preserved ejection fraction. It can be heart failure with reduced ejection fraction, can be due to ischemia or other causes also. Common risk factors are age on the higher side, race, gender, hypertension, diabetes, and other risk factors. We have lots of modulating factors. That is a lot of systems that get activated in case of heart failure, like the sympathetic nervous system. We have the RAS system. We have the endothelial dysfunction and inflammation that goes on in heart failure cases. So all these things precipitate heart failure and at the same time impact the kidney function. The important pathophysiologic changes that happen over a period of time is there is gradual nephron loss in these cases, reduced gradually worsening GFR levels, so that some medicines that we could have given earlier couldn't be given over a period of time. Then we have progressive renal fibrosis and albuminuria. When we talk about the heart, gradual reduced cardiac output, increased wall stress, and increased venous congestion again impact the kidney blood supply, and this again gets worsened over a period of time. So it is a vicious cycle that the patient goes into, and these patients have readmissions for recurrent heart failure, and their prognosis gets worsened for each admission. So when the worsening renal function occurs commonly in acute heart failure, that is to the tune of 30 to 50% in these cases, when they are hospitalized, they generally have either a decreased cardiac output state or a venous congestion phase. The reduced cardiac output reduces the blood supply to the kidneys. The worsening congestion leads to the venous congestion of the kidneys. So the GFR gradually goes down over a period of time. When there is late phase of the hospitalization, the RAS inhibition can help these patients, and we can control this renal dysfunction to a certain extent. So challenges in management of these patients will be, while treating volume overload, we tend to over-diurese these patients. This again leads to acute kidney injury and worsening renal function. And at the same time, when we start AC inhibitors or ARBs or ARNI in these cases, there might be some renal dysfunction that might be precipitated due to these drugs. So we have to walk a thin line between these two cases, these two aspects, and treat the patient well. RAS initiation is life-saving in these patients despite the renal dysfunction, and whatever the stage of therapy or whatever the stage of presentation, we have to try to start these patients on RAS inhibition, because if we have started these patients, whether early or late, their long-term prognosis gets impacted. So conventional heart failure therapy, when we give MR antagonist or RAS inhibition in the form of ACE inhibitors or ARB, the potassium levels is what we need to monitor very frequently, because it is in the RAS trial, it is observed that hyperkalemia was there to the tune of 13%, for FSS trial 16%, and FSS-HF to the tune of 12%. So as the potassium levels go on the higher side, the prognosis becomes that much poor. So we have to be very careful when initiating RAS inhibition as well as MR antagonism at the same time. And this hyperkalemia increases with decline in renal function. So when we talk about GFR levels, if the eGFR is more than 60, the prevalence is lesser. Less than 60, the prevalence increases. And impact of this hyperkalemia is to the tune of 9%. These patients will have hyperkalemia. 10 to 38% of hospitalized patients who received an ACE inhibitor develop hyperkalemia. So MR antagonism with ACE inhibition, nearly 40% will have hyperkalemia, and 10% of patients prescribed ACE inhibitor developed severe hyperkalemia within 1 year of follow-up. So we have to keep a regular check on the potassium levels, not only during the admission but during follow-up also. Therefore, there is a need for a therapy that reduces hyperkalemia incidence in these heart failure and CKD patients. So ARNI is the one medicine that is preferred, even if we can give ACE inhibitor ARB. Now it is a class 1 indication, and the incidence of hyperkalemia is less in these cases. So it is less likely to cause hyperkalemia and worsening of renal function. In fact, it preserves renal function. So when we start ARNI or any heart failure therapy in the initial phase, we tend to preserve the kidney function over a longer period of time. Even if you are not able to start it in the early phase, try to get it on board as soon as possible, so that you can reduce the rate of decline of the kidney function. SGLT2 inhibitor also same, it helps the kidney to survive longer. What do the guidelines recommend? Initiate RAS inhibition in the form of Valsac as first line therapy in all cases, whether it be SEC 2024 guidelines, ESC guidelines, or Indian consensus. They all recommend ARNI as the first line of therapy in case of heart failure. Then when it comes to dosing adjustment, generally we don't need dose adjustment till the GFR levels are less than 30. So you can give it as a regular dose therapy. So it improves the LV function to the tune of 5.1%, 27.5% increase in quality of life in these patients, and there is lower incidence of elevated serum creatinine levels over a period of time. So this therapy preserves kidney function over a period of time. And ARNI delayed the progression of GFR, decline of GFR as seen in this meta-analysis. There is also 11% reduction in risk of worsening heart failure with ARNI. So lesser number of re-hospitalizations and lesser number of prognosis is that much better. So to summarize, the renal dysfunction and heart failure are a real thing. They are there together very frequently. So we need to challenge both these aspects very well. And ARNI is the first line of therapy in case of heart failure with kidney dysfunction, as it helps in preserving the kidneys and the heart at the same time. Thank you.